A few matters to go ahead and discuss. My name is David Dukas. I'm the director of the Division of Medical Humanism and Ethics. And what I wanted to do is go over what we're doing this week. This is a very unusual opportunity we have here at the University of Louisville. Rather than having repeated Dean Scholars coming on a monthly basis, we're stringing together a series of talks this week as part of the Dean Scholars Week. So we're doing a debate today, loosely defined, and as you can see here on healthcare reform, followed tomorrow by Dr. Ware on producing, evaluating, and implementing advanced directives, which is an area near and dear to my heart and to others in this audience, as well as on making and implementing clinical judgments of futility by Dr. McCullough on Wednesday, again here at noon. So not only are they doing those three sessions, but we have spent the morning in SICU rounds. We will be with family medicine tomorrow, but only after doing grand rounds in OBGYN. Geriatrics will be having a session from 3 until 4. We are also having a resident session with OBGYN for 2 hours on Wednesday. We will be precepting with the residents out at Cardinal Station out on Thursday. And we will have sessions of grand rounds with surgery and with family medicine residents on Friday. A very, very busy schedule. But it is my hope that this will be a wonderful shot in the arm in terms of doing what the visiting scholars are supposed to be doing, which is to give advice and to improve the overall curriculum of medical ethics and humanities here at the University of Louisville. Very importantly, if you can't make one of the 3 noontime sessions, they live on in 2 places. One is at the Division website, Division of Medical Humanism and Ethics. So if you ever go to a louisville.edu domain and there's a search box, and if you just look up humanism, it will take you straight to the Division of Medical Humanism and Ethics. Second, if you have iTunes on your computer, whether there's a PC or a Mac, you are able to look at the entire presentation plus their slides at iTunes University. So they're all uploaded, and it's usually about 2 weeks in. So if you wish to go ahead and podcast all of these series, we have all of our lectures that have been done by our presenters since February of 2005. And so you can go ahead and look at those, use them for classes if you wish, whatever you would like to go ahead and do. Now it is my distinct honor to introduce our 2 speakers. Dr. Laurence McCullough is a colleague and friend. He is the person who is responsible for me standing here before you today. If it were not for him in 1979 recruiting me saying, you really ought to do bioethics, after I had just written a fairly forceful argument on bioethics and termination of pregnancy back at Georgetown University, a fine Jesuit institution. He said I should continue on in the field. I probably would not have done what I did. I probably would have hung out a shingle and been a nice family doctor somewhere out and done just clinical practice. But it made me change the way I thought about what I would be. And to that I hold him in high regard, and I have a great debt to him. Dr. McCullough is the inaugural holder of the Dalton Tomlin Chair in Medical Ethics and Health Policy at the Center for Medical Ethics and Health Policy at Baylor College of Medicine. He's also the Associate Director for Education there. He's also an adjunct professor of ethics in obstetrics and gynecology and of public health at the Weill Medical College in Cornell University, where he's had a long-standing working relationship with Frank Shermanack, who's chair of OBGYN up at Weill Cornell. He's authored more than 400 articles, case studies, and editorials in peer-reviewed literature, and has had 12 books in such titles as Medical Ethics, The Responsibilities of Physicians, Ethics in Obstetrics and Gynecology, Long-Term Care Decisions, Ethical and Conceptual Dimensions, and he's also co-edited Medical Ethics Codes, Opinions, and Statements, as well as the Cambridge World History of Medical Ethics. Dr. McCullough received his A.B. in Art History from Williams back in 1969 and his Ph.D. in Philosophy at the University of Texas in Austin. You'll hear that again in 1975, and did a postdoctoral fellowship at the Hastings Center. He also had previous appointments at Texas A&M and at Georgetown University, where I met him many, many years ago. Dr. Stephen Ware is from the University, SUNY Buffalo, State University of New York in Buffalo. and he is Associate Professor of the Department of Medicine at SUNY Buffalo and also holds adjunct appointments in the Department of Gynecology-Obstetrics and the Department of Philosophy there. He's the co-director of the Center for Clinical Ethics and Humanity in Healthcare at SUNY Buffalo. And he has been a visiting scholar of the Hastings Center, Research Associate of the Kennedy Institute, and Fellow at the Institute for Medical Humanities at the University of Texas Medical Branch in Galveston. He received his BA in philosophy from Windham College and then went on to his Ph.D. in philosophy from the University of Texas at Austin. There's the commonality. They actually knew each other many, many years ago. So it is a great pleasure in which you'll have first Dr. McCullough and then some response by Dr. Ware on ethical challenges of healthcare reform. Please, let's get them away.
Well, as I learned to say at Texas A&M, howdy, y'all.
Howdy.
All right. Howdy. Are there any Aggies in the room?
No.
Oh, boy, I am bereft. David left out that one of the finest accomplishments in Dr. Ware's life was to stand up as my best man. To the woman to whom I am still married, lo, these many years later, a testimony to the virtue of patience in our species, about which I will say no more than what I've just said. Oh, this is going to be difficult. Okay. So this is ethical challenges of healthcare reform, and what I want to do is first just make some brief comments. We keep using the word healthcare system, but we don't have a system for healthcare in the United States. We have a healthcare gemisch, and I'll explain what I mean by that. And then I want to look at two main goals of healthcare reform. First, creating a source of payment for nearly everyone. Massachusetts has done the best. They're at about 97%. There seems to be a residue of people you're just not going to get in the system, no matter how hard you try. And then bending the curve of inflation and health care costs downward. That is, making less steep the rise of the cost of medical care. Not reducing it. You can't do that. But you can flatten that curve of inflation before it breaks our economy. And then look at identifying two ethical justifications that have been given for the first topic, creating a source of payment for everyone, and then explain why, as a matter of professional integrity, we must bend the curve of inflation downward. It doesn't matter what government's in place, doesn't matter what health policy is. This obligation exists independently of public policy and, in fact, should guide public policy. I should add that there's an underlying assumption in this presentation is that leadership in our society comes from below. We elect officials who are very good at figuring out what direction we're already marching in and then running to get to the head of the parade and taking credit for it, which is perfectly okay with me. I take my instruction on our politics from one of the framers of the American Constitution who reputedly said in 1787 when they finished their work, "We have now designed a government that can be safely run by devils." And I live in Texas. We know devils. Stephen and I used to go watch the Texas legislature when it was in session in Austin because graduate students in that time had no money. And I used to think of the Texas legislature, and still do, as a spectator, as free, entertaining, and terrifying all at the same time. It's amazing that our country gets from one day to the next under our form of self-government. But of course it beats English royalty, which we threw off. And then I want to look at the leadership role for healthcare professionals in all of this, because that is neglected in our debates about healthcare reform. So first, we do not have a system for healthcare in the United States. A system means a rational, coherent, and centrally managed way of providing a service or making a product. We have a healthcare gemisch, a wonderful Yiddish word that comes from the German past perfect participle gemisch, and it means a mixture or blend of things, a mishmash or a melange. Ideally, a gemisch should be tasty, because it's a term of it's a culinary term. But our gemisch reflects a fundamental American value, and that is we fear concentrations of power. So our healthcare non-system looks just the way it does because we fear power being concentrated. And we do the exact same thing for education, for transportation, for food production and distribution, for national security and defense, and many other vital social functions. I have not yet heard a report that any United States Coast Guard cutters are currently participating in the military operations against the country of Libya. But it will not surprise me to learn that Coast Guard cutters are there. They were actually in on the invasion of Kuwait. They were in Vietnam. And the reason is that the Coast Guard doesn't want to get left out of a war because then your budget gets cut. But we have 5 branches of the armed services to protect us from the armed services. In 1983, when I was at Georgetown, I attended a national conference of the senior leadership of the United States Marine Corps, starting with the commandant. The lowest ranking person in the room was a 1-star general. And at lunch on the first day, I sat with a table full of generals, and I said, gentlemen, have you ever contemplated the scenario in which the United States Army launches a coup against the government of the United States, and the President of the United States calls you and asks you for help? And they all got big smiles on their faces and said, Dr. McCullough, we've been waiting 200 years for that opportunity. We would go over there and kick their butts. Other countries have a single armed force. They are actually comfortable with that, which is, of course, deeply un-American. So it is enormously inefficient. It spreads out power. It is very difficult to manage, and so it looks the way that it does. Up until very recently, I think it was still true, we only had one system for minting coins and printing paper money, but now there is electronic currency that banks control. And so actually currency in its full range of forms is now a gamish along with everything else. Is this a great country or what? So my 2 topics, creating a source of payment for everyone and then managing the cost curve downward. For the first topic, there are 2 ways to do this. The one that dominates our public discourse is appealing to a universal right to health care. And the second, much less dominant, is the notion that we all share an obligation to remove financial barriers to health care. And I'm going to suggest the second approach is politically and philosophically much more attractive than the first. But let me take you through the first. We mix up 2 discourses in rights talk. One is natural rights and the other is human rights. And we must disentangle these because it turns out natural rights won't do the work for us. Only human rights will do the work. So what is a right? It is a justified claim against others to be treated in specified ways. Notice the very exciting philosophical distinction between negative rights and positive rights. In philosophy, you are not rewarded for being exciting. You're rewarded for being clear. So a negative right is a right to non-interference, and these are very powerful rights because they don't make a claim on any of your resources. So last night, none of you interfered with my negative right to an undisturbed night of sleep because none of you were outside the Brown Hotel making noises to keep me awake, although there were people on motorcycles doing a very good job of that. So they actually violated my negative right to be undisturbed. I called the local police and they said that was not a priority for them, and that was the end of that matter. But setting limits on negative rights is very hard to do. And it's basically the harm principle. You've got to be shown to be causing someone else to be a grave risk of harm. Positive rights are very different. It's where I lay a claim on the resources of others to advance my own interest. And all all positive rights come with limits. The only question is where the limit should be set, something that Americans forget when we assert our rights. We all think our rights are negative rights, and they don't come with limits, but health care, of course, is a positive right. It is a claim on the resources, time, and efforts of other people. Healthcare professional like Dr. Dukas and his clinical colleagues here at the University of Louisville, healthcare organizations like this medical center and its hospitals and clinics, and of course on public and private payers. So when I go to see doctors in Houston, I am making a claim against the resources of my medical school because it is a self-insuring employer, and I am using not my money but my employer's money to get my health care. Now, natural rights are a very old discourse, and these are rights that we have before the creation of governments, and therefore which governments must protect. That's what natural rights are designed to do, is to have a source of intellectual and political autonomy that precedes the existence of states. However, if you're not at least a deist, if you don't believe in a creator God of the universe, you can't be a natural rights theorist, despite the fond hopes of people like Leon Cass to the contrary. You just can't pull it off without a deist God to create the rights. And the great scholar and philosopher of this was John Locke, who, by the way, was a physician. So notice his list of natural rights: life, liberty, property, and health, not health care, right? Because in the late 17th century, going to a physician was downright dangerous, and everybody knew it. And going to a hospital was something only very desperately ill people would do. And it was philosophically controversial once it's recognized that there's no fixed human nature. Locke did his work before Darwin. After Darwin, there's no such thing as a fixed human nature from which we can derive natural rights. You just can't make it wash. Locke based it on the best science of his day. We have to base it on the best science of ours. The science doesn't support it anymore. But suppose it did. Natural rights are negative rights. You can't get a right to health care out of a natural right to health. What you can get, for example, is a right to safe food. So there better not be toxins in that nice and delicious chicken salad sandwich I just ate. That would violate my negative right to health. Now, human rights is a discourse that was invented at the end of World War II. And it was meant to be an international movement that you wanted to get everybody to sign on to. And the goal was to create a set of rights, not discover them, that over time, if advocated and re-advocated, would be adopted by societies and then by states to secure basic human, economic, social, and political rights. And the reason that the foundation or basis of the rights was finessed, that is, as a term from Bridge, you're just going to pass by the Trump suit if you can, is that if we focused on the reasons why people thought such rights existed, human rights movement would have died in its cradle. It simply would not have happened. You're not going to get people from the Islamic world, the Judeo-Christian Western world, Buddhists and Hindus in Asia, and good old boy atheists from the hill country of Texas in a town called Utopia, where there is a monument to atheists in Texas, right? Isn't that wonderful? They're simply not going to agree on where these rights come from. So the goal is to assert the right and assert it over time and then eventually back it with state power. The most vivid example we can see is coalition forces are enforcing the human rights of Libyans as we speak by dropping heavy ordinances on the forces of the government of Libya to force them to stop fighting. That's an enforcement of human rights. There would be no legitimacy to that military action now unless the discourse of human rights existed to support it. And if you listen to the President of France, the Prime Minister of the United Kingdom, and our President, they are all using the discourse of human rights to justify this military action. We've created a whole bunch of human rights in our society. People who are privately insured have an employer-created human right to health care under the terms of your contract. People in federal systems such as Veterans Health Affairs and the Indian Health Service, who are responsible for millions of our fellow Americans. If you are in a corrections facility run by any level of government, you have a human right to health care granted explicitly by legislation. If you have Medicare, Medicaid, which is the program for the medically indigent, and I put in the example of Harris County Hospital District. These are county-supported charitable hospitals in our state for the worthy, sick, poor. You have to have a Harris County Gold Card, it's called, to get into the Harris County Hospital, unless, of course, you come into our world-class emergency department where you will get the best trauma care in the world. Sorry, Louisville, you guys don't come in first. That's just a fact. That's not Texas chauvinism. You want Texas chauvinism? I can give you plenty of that. And, of course, you have EMTALA rights. If you arrive in the care of any healthcare professional or healthcare organization and you are medically unstable, you have a right to be worked up and stabilized regardless of your source of payment. After that, you're on your own. Right? By the way, the Congress never appropriated a penny to pay for this in the very same session where they passed a law making it illegal for the federal government to create unfunded mandates and then ignored their own law. Why not? Active duty military personnel and their dependents are covered by the medical corps. Now with the VA, some of the finest medical care in the world, way ahead of the private sector in doing what I'm going to talk about in the second half. And then the wonderful program called TRICARE for retired military personnel, which is a publicly funded insurance program with a wraparound for-profit managed care plan. And I've got a very good friend who helps to run it, and he cannot tell me what it is except what I just said. And he's been trying to figure it out ever since he's worked there. Extremely complicated, and just what you would expect the United States Congress to create. Now, what's the problem? Why should we create this human right? First, we know of the following as a fact. People without a source of payment delay going to their healthcare professionals, and they tend to come to emergency departments, and they tend to be much further into the course of their disease or injury than they otherwise would be. They are therefore sicker, they do more poorly, and they cost a small fortune. This is simply unacceptable in the ethics of patient care and public health. It is simply an affront to professional integrity, and no conscientious healthcare professional should accept it. This is what motivated then Senator Dr. Kitzhaber in the state of Oregon, who was an emergency room doctor, a very important piece of his history, to do something about this. And of course, there's a vicious synergy between socioeconomic status and health. The best predictor of your health status is your socioeconomic status, and the best predictor of your socioeconomic status is your health status. This systematically discriminates against poor folk, who tend to be politically disenfranchised, so we can get away with it, but it's simply not acceptable because it has lifetime effects on people. You have a child who's uninsured, comes in with an asthma attack to the Ben Taub Hospital in Houston, is going to get very good pediatric care, and then everybody's going to struggle to provide continuity care after that, and that creates a huge problem that has lifetime effects. The economic burdens on providers are growing. The unfunded mandates are now beyond management. The Texas legislature is about to cut Medicaid appropriations in our state by 50%. This will simply bankrupt hospitals all around the state. It's unavoidable. And the only way they'll be able to deal with this is they will shut their doors to elective Medicaid admissions. And who's going to take care of those people? Our legislature has absolutely no answer. And this creates the violation of justice called exploitation. That is when a large group, that is those of us who are economically well off, gain an economic and political advantage by burdening a small group that gets no offsetting advantage. So 80% of the Medicaid nursing home beds in Texas will be closed by January of next year if the bill passes. That's a completely vulnerable population, and they and their families will be hit with significant burdens, but they're a small number, and so we don't care. Or at least our legislature doesn't care. To be more precise, the Republican majority in both bodies, for the most part, doesn't care. Some of them are waking up and realizing the disaster that is looming, and the political winds are shifting in Austin just in the last week. There's some of the leading Republicans that said, wait a minute, this is not what good Texans do. So maybe things will be different in the next couple of weeks. And of course, we're the only industrialized nation without a universal source of payment. Talk to any business person who works in international markets, and they will tell you this puts us at tremendous competitive disadvantage against every other country in the world who have very high health care costs, but they're on the government's budget, not employers' budget, and we get tremendous economic disadvantage in that. This is one of the major reasons why major industry groups supported the president's health care reform. They see it as the first step to transferring their costs to the government. Now, that's the rights-based discourse. I think the much better way to think about this is to think about whether we all have an obligation to remove financial barriers to health care. And this was proposed by the President's Commission way back in 1983. They said, look, rights talk divides us. Don't use it. We can all agree on an obligation, even though we will have very different reasons for coming to that agreement. So the former mayor of my city, Bill White, and past and failed Democratic candidate for governor, when he came to speak to our local political club when he was mayor, said, here's how I think Harris County, Texas, has the highest rate of uninsured in the country, 1/3 of our population. That was 2 years ago. I'm sure it's gone up since then. He said, I was raised a devout Southern Baptist, and in my Christian faith community, it is wrong that the sick poor are not cared for appropriately. This is not what Jesus expects of me. We need to do something about this. Then he said, some of you may be Jews, some of you may be Muslims, some of you may be good old boy atheists. You could agree with me that we have an obligation to do something about this, but your starting point won't be the convictions of a Southern Baptist. It'll be the convictions of a different kind of starting point. This is the genius of it. We can start from all of our pluralism, religious and secular, can stay in place. We can start from our separate convictions and reach the judgment that this is something we ought to do about, and we avoid all the divisive language of rights talk. So I recommend that we take the obligations-based approach. If you listen carefully to the president during the debate about the health care reform, he never used the language of a right to health care. He avoided it. He used the language of obligation. That's his Christian conviction speaking. He kept that suppressed because you don't need to attend to that. It counts as he thought there was an obligation. So that's the first part. We should talk about an obligation to provide health care, not a right. Now, bending the phrase, the cost curve downward. How many of you do not know the name W. Edwards Deming? Do not know it. Okay, this is a name you must know, and his concepts, or you cannot understand the concept of quality in healthcare. Deming got the idea, brilliant idea back in the 1950s, that uncontrolled variation in a production or service process results in very wide variation in the outcomes, and it costs a manufacturer or service provider a fortune to fix the errors. And he worked with the automobile industry, who ignored him because we could afford the inefficiency because we had no industrial competition in the 1950s and 60s because World War II had blown it to smithereens. There was simply no other automobile or heavy industry in the world except in the United States and that little tiny country to the north of us called Canada, which has about 15 people in it and one factory. So it doesn't have much effect on... No, back then, Canada was about 15 people in Toronto with one factory. Or as we say in Texas, a teeny little country. So what is quality? You progressively and responsibly, there's a powerful ethical component in this, minimize variation in a production and a service process, which should reduce the variation in outcome and thus bend your curve of inflation downward. That's how it works. So in an automobile factory, you can get every bumper to stay on. And how did Deming do it? He went out on the assembly line and asked the people on it, what's the problem? Why are bumpers falling off? And they said, well, Mr. Deming, we have to bend over to bolt the bumpers on, and we get a lot of back injuries, and so we don't stay in that bent over position long enough to make sure the bolt is at the proper torque. What should we do, said Mr. Deming. They said, design an assembly line so the car comes up, and we're just pushing the drill straight ahead, put the torque wrench on it, and send it to the next station. He said, good idea. American industry said, pfft, and he went to Japan. And by the 1970s, the Japanese people were preferentially buying Japanese label automobiles, which cost about 10 to 20% more for purchase with no maintenance costs, except oil changes and tires. That was it. And to this day, the prize for industry excellence in Japan is called the Deming Medal. Right? He got it. So what does this mean in healthcare? The processes of patient care should vary as a function of the natural history of diseases and injuries and the response of diseases and injury to clinical management of them. We can't get the bumper to stay on 100% of the time in healthcare, but we can get it to stay on a lot more frequently than it currently does. What is professional integrity? How does this hook up? It requires healthcare professionals to continuously improve the quality of care, to progressively reduce that variation. Because if you don't, your patients are sicker and it's your fault. That violates professional integrity. Who invented this idea in the history of medical ethics? Not Larry, John Gregory and Thomas Percival 230 years ago in Scotland and England. This is all in Percival. He has a whole system for quality control in the Manchester Infirmary in his book on medical ethics in 1803. I've showed it to quality experts and they're stunned. They all say he got it. He doesn't get the detail of it, but he had the concept of evidence-based medicine, rigorous accountability, changing the process of care based on assessing their outcomes. He had the whole process that we now take for granted. Now, the current rates of inflation, if we don't bend them downward, are going to break us. Medicare, of which I will be a beneficiary, thank you all very much, you'll be paying for it. Medicaid and Veterans Health Affairs. When the veterans of the last major military action, starting with the Gulf War against Iraq's invasion of Kuwait, start coming into the VA system as they age, it's going to be frightful. The domiciliary cost for veterans who require nursing home beds is breaking the VA. If you ask General Secretary Shinseki about what he's most concerned about in Veterans Health Affairs, just say domiciliary beds, and the general will fall over with a metaphysical arrest that only Steve and I and the other philosophers in the room can treat. Cardiac arrest, easy. Metaphysical arrest, you need a philosopher, right? Employers are dropping health insurance. We know that. Since healthcare reform is passed, employers are still dropping health insurance. That is still going on. They will lay off employees. In 1995, I think it was, my medical school ran a $500,000 deficit in its health plan. The next day, they fired 50 non-faculty employees. That's how they balance the budget. Because my health care is more important than their jobs. Right? What kind of Texans are you? Let me try that again. My health care is more important than their jobs, right?
Yes, Larry.
Right. Of course not. What theory of justice supports that, especially since doctors at Baylor are still learning the concept of evidence, much less evidence-based practice, about which more I will say nothing. Take-home pay is being depressed because our employers have to keep spending money on health care. There are increased economic burdens on patients and their families as we now enter the era of underinsurance. So my out-of-pocket liability when I came to Baylor in 1988 for myself and my wife was about $500 a year. It is now $8,000. Have been shifted onto me by the premium PPO. I could escape that by going to the HMO. My employer gives me an option, but that's the cost shifting onto me. And I'm a rich, full professor who holds a chair, so what's the problem? Think how many philosophy books you can buy with $8,000. This is serious stuff. They only cost about, what, $2 each, Steve, if you buy them used at half-price books, right? Care burdens are being shifted onto families, right? When Medicaid in Texas cuts and 80% of the nursing home beds at our state are closed, their families are going to have to step up, translate women. So this is women's work, and this will be transferred on to women in our state. Many of them unable physically to provide that care. That's why their loved one is in the nursing home. And of course, this creates unacceptable opportunity costs in the federal budget as health care costs dislocate the entire federal budget. This reached a crisis in the Ontario province in Canada already in the 1990s, where 1 year teachers got no salary increase because of the frightful increase of health care costs in Ontario province. They promptly went on strike, and the Ontario legislature said, strike, go ahead. We don't have any money. Why? Because uncontrolled variation in healthcare. This is all crazy. Is our country slowly waking up that the gamish is not working? Well, the Congress passed the bill, so yeah, we are waking up. It worked. Remember what Prime Minister Roosevelt said the day after Pearl Harbor, allegedly, was that Americans can be counted on to do the right thing, but only after we exhaust all of the other alternatives. And so we're still into that process. Churchill, sorry, who did I say?
Roosevelt.
Oh my God. I apologize. Never should an American president be thought to be the chief executive officer of that tyrannical government that sits in London and oppresses the Irish and the Scots and all their fright-thinking people everywhere in the world. Right?
There you go.
These are fighting words. Just visit Scotland, they'll tell you. Okay, what does history teach us? The first great experiment in bending the inflation curve downward was Medicare, which had wide area variation evidence showing that the average length of stay east of the Mississippi was about 3/4 of a day longer than west, with no effect on outcomes. So they went to the prospective payments as a way to give hospitals the incentive to shorten length of stay, and it worked, and bent the curve of inflation in Medicare downward during the 1980s. The private sector was watching and tried to do the same thing and invented what I call poorly managed care. Just pay doctors and hospitals less. For about 5 years in the 1990s, the rate of inflation in private health care was under Medicare's rate and under the federal level, but then it shot right back up because doctors and hospitals very quickly learned to unbundle their services, bill for them separately, and costs shot right back up because the uncontrolled variation was going on full tilt. Because it's in the economic interest, by the way, of doctors and hospitals. It's not in the interest of any hospital to use imaging and lab services at the correct rate or an evidence-based rate. It's in their interest to use it to the maximum rate because that's where the profits are, plus the NICU. Those are the three profit centers in a modern hospital. So it worked, but only temporarily. So what was going on at the same time in the Kaisers around the country, other plans, Geisinger Clinic in Pennsylvania, and other groups, Mayo, the clinic models like Cleveland Clinic, Mayo, and Scott and White Clinic in my state, invented what's called well-managed managed care, and this is where healthcare professionals lead continuous improvement of quality that is bringing that variation down responsibly with strong organizational support, and this works. You can get uncontrolled variation managed, the variation starts to come down, the outcomes improve, and costs plummet. And one of the fine examples of this is how Intermountain Healthcare, which is a system based, I think, in Utah and runs down the Middle Rockies, reformed how they treat community-acquired pneumonia in their emergency departments. They discovered their outcomes were all over the place. Their costs were out of control. This is a very common diagnosis, and if you got an unnecessary admission, is a very expensive diagnosis. The leadership of the hospital did not tell the ED doctors what to do. It gave them the data and said, fix this by reducing the variation. The first thing they did was look at the antibiotics they were using. I think it was like 60 different antibiotics were being used. They then looked at the evidence and found, David, there were maybe about a dozen or so first-choice antibiotics that are shown to be effective against that. You don't stick with them blindly. The patient doesn't respond. The guideline has the next drugs. And they immediately found that their rate of success went way up. Their admissions went way down. So you had healthier patients who cost less money. It's exactly how it should work. We know that this works. And so healthcare professional-led continuous improvement of quality means that physicians and nurses give up their autonomy to do it the way they want to do it the way they should do it. Now, this is a concept you can utter in my medical school only if you have tenure, right? We advise all junior faculty not to speak up on this, right? But senior faculty with tenure can say this because we are protected. I mean, I gave grand rounds on this in one of our departments last year, and I thought the department chairman was going to decapitate me. He simply did not want to hear this. I had to say, fine, you want to be on the losing side of history, go ahead. But you're taking our whole medical school with you, so you're not free to do that. So professional integrity says you have to do this, because professional integrity says you should be aiming to produce the healthiest patient as the outcome of the process of care that you can. So what do we know from history? Healthcare professionals do not control all of the processes of care. They only control the part for which they're responsible, which is a big chunk of it, but not all of it. Healthcare organizations have influence on the processes of care, what equipment they buy, how many nurses a hospital uses, how many beds they have open, how they staff an emergency department. All of these organizational decisions have a direct effect on the processes of care. And of course, patients and their families control the processes of care, especially patients with chronic diseases and injuries, because that's where the money is. Right? This is where we were spending our money. Poorly managed diabetics cost us a fortune, and they get sicker. Their lives are worse. Right? I teach in a VA. I don't know how many times I've seen patients lose their limbs to amputation from that horrible disease when it was all preventable if they'd just taken their meds, maybe had a better diet. When my father-in-law was alive, there was the Sam Quintanilla diet for diabetics. And this was Sunday morning breakfast at one of the East Side bakeries in Austin, where we would have pan dulce and beer for breakfast. Now, pan dulce is a wonderful Mexican sweetbreads that's about 1% flour and 2,400% sugar. Washed down with beer, of course, right? He lived to be 89 years old, so it worked for him. But he lost his leg to that terrible disease, and his sight, and his kidneys, and eventually that's what killed him. So we have at least 3 players controlling the processes of care. Healthcare organizations can influence healthcare professionals. We know that from the Medicare experiment. It worked. Nurses were empowered to hector doctors to shorten the length of stay in the 1980s, and it worked. When I was at Georgetown at the time, I used to joke with the director of social work. I asked her one time, when does discharge planning begin? She said in the old days it was the day before they went home. Now it's the day of admission. But in the future, it will be from the moment of conception. I thought a very nice Roman Catholic theological approach to discharge planning, right? You get your genome and your discharge plan upon conception. This will change. This would actually be a new billable for IVF services. I hadn't thought of that till just now. And then, of course, payers can influence the processes of care, especially by how they use or don't use co-payments and deductibles. One example I was given to Dr. Weir was in the New York Times a couple of months ago. A number of the big health insurance plans have realized that if you take away all co-payments and deductibles for doctor's visits and medications for patients with chronic diseases, lo and behold, they see their doctors, they take their medications, they're much healthier, and the costs come way down for taking care of them. None of this is rocket science. It's actually, my view is if the ethics professor can figure it out, it's not that hard to figure out. So what are the ethical dimensions of this? Unconstrained exercise of healthcare professional autonomy is inconsistent with professional integrity, and as Gregory and Percival said 200 years ago, it must stop. This cannot go on. And claims my patient comes first, who are you to tell me how to practice medicine or nursing? That's professionally irresponsible and it has no intellectual authority and no moral authority, and no administrator worth his or her salt should accept it. Unconstrained exercise of organizational power, on the other hand, to try to influence the processes of care that is disconnected from the well-being of patients and simply driven by the economic bottom line, that's not ethically acceptable either. By the way, combined uncontrolled quality and economically driven healthcare organizations, and you get an ethical formula for what Laurel and Hardy called another fine mess you've got us in. And it's going to take a long time to straighten it out. Patients don't get unconstrained autonomy either, even though they think they have it. Right? This is America. I have my rights. Yes, you do. They're all positive rights, and they all come with limits. We're not obligated to give you anything you want, only what works. And by the way, we're not going to let you buy it even if it doesn't work, because that has a dislocation on capital allocations in our healthcare organizations. It is not a benign strategy. You simply can't let people buy above the appropriate level of care. So what's the preventive ethics response to this? That is to lead change and not react anymore. Is healthcare professionals should take a leadership role in continuously improving the quality of the processes of patient care for which they're responsible, to create accountable care organizations. This is the core of the healthcare legislation. And it will survive because the insurance companies are insisting on it. It's not going to go away. If you appeal accountable care organizations, then Aetna will just do it by itself. And United Healthcare, they are all going in this direction. I'm privileged to teach at Texas Children's Hospital. Everything is going on a guidelines-based approach. I'm part of the gender medicine team. We have a protocol for the management of infants with ambiguous genitalia. We are now writing a protocol for the management of fetuses in the fetal center with ambiguous genitalia. We're going to have a guideline for that too. That's as evidence-based as we can get it, so the variation is not over the place. If you're being assessed just by outcomes, clinicians in the room, you should resist this, because you're not in control of those outcomes. You're in control of the processes. So accountability for the processes of care for which you're responsible is not something you can escape, and in fact you should embrace it as a matter of duty. But if you're being measured just by outcomes, that's unfair. Why are we measuring outcomes? Because they're cheaper and easier. It is expensive to measure adherence with processes of care, although with new electronic medical records it should get less expensive. Next, healthcare organizations must support healthcare professionals in taking this leadership role. Intermountain Healthcare is a good example. Their leadership got behind those ED docs and it became a model. And then we've got to improve the processes of care for which patients are responsible. So first, support healthcare professionals, and then support and incentivize patients and their families. Next, healthcare professionals should recover their authority in the informed consent process. You have no ethical or legal duty as clinicians to tell a patient about something just because it's technically possible and physically in the building. You're expected to make a judgment in your expertise about whether that's clinically beneficial, and that's the only thing you offer to patients. So for patients with advanced dementia, we discovered by the mid-1990s, PEG tube placement and administration of nutrition and hydration by that route did not alter the outcome. So you don't offer it anymore. If families demand it, you refuse. And no competent geriatrician orders a PEG tube in this patient population, right? Right? That's an example of evidence-based medicine from about 93 to 97. Totally transformed the care of that patient population. And by the way, you've got, since it didn't change the outcome, the savings were ethically perfectly acceptable. Nobody was put at risk to achieve them. So you present the decision maker only with medically reasonable alternatives, and you school them in the discipline of evidence-based reasoning. So if mother insists that the 3-year-old with uncomplicated otitis media is going to get the Z-Pak, the answer is no. Now there's the article in New England about a month ago saying maybe aggressive antibiotic therapy prevents, in a subpopulation of kiddos, reinfection. Then that subpopulation would be a candidate for antibiotic therapy, not to treat this infection, but to prevent reinfection. And you simply do not implement requests for clinical management that lack an evidence base of expected net clinical benefit. That's got to stop because it's unnecessarily over-treating patients, which is not benign. Healthcare organizations need to back you up when you do this. The example given in my medical center is from my pediatrician colleagues is they say, okay, Larry, what if mother plunks her purse down, it hits my table with a rather large thud, and I remember that in Texas you can carry a concealed firearm. I said, well, then you need to have the hospital administrator come down with a shotgun and level the playing field and say to mother, no, we're not going to do this. What if she wants to doctor shop? If there's a practice guideline for the whole group, she can't. Right? And by the way, is this paternalism? Yes, it's interfering with mother's autonomy for her child's own good. You bet it's paternalism. It's also justified. It's negative rights that we don't want to interfere. It's positive rights we can limit all over the place when they're justified in doing so. Healthcare organizations should continuously improve the processes of care for which they're responsible. If your medical center is not doing this, I would be shocked that this is not going on. Is not hand washing in the intensive care unit acceptable in this medical center? Right? Do you have the signs up saying it's okay to ask your healthcare professional if he or she has washed his or her hands? Right? Of course. Is it okay to chew a colleague out who doesn't wash hands first? Yep. Just say, go back and wash your hands. By the way, when I go on the floor to do ethics consultants in the intensive care units at St. Luke's Episcopal Hospital, I have to wash my hands. I don't know how an ethics professor is a vector for infection, but I wash my hands. That's the rule. By the way, we're going to get rid of ties. This will be a godsend to those of us who find ties a source of restricted airways, and thus a barbaric instrument of accoutrements, right? So notice, evidence-based reasoning, by the way, this is evidence-based reasoning. Your clinical judgment is held against the best available evidence. There's always evidence better than your own clinical impression, except for the true zebras. But there aren't many of those in clinical. Most diseases fit very common patterns, and then you become an accountable healthcare organization, and in the new environment you will flourish. But all you got to do is follow professional integrity to get there. Now, patients have to learn this. Patients have to learn that they are intellectually obligated to accept that if they're going to use their language of a right to health care, it's a positive right, and it comes with limits, and that comes from evidence-based reasoning. Like it or not, you're not entitled to your beliefs. When you are making statements of fact in the clinical setting, you are subject to scientific discipline. You don't get to believe what you want. It's just not allowed. Why? Because that's dangerous for patients. So patients are obligated to accept that poorly controlled and uncontrolled variation results in mistreatment, overtreatment, and undertreatment. That's not good for you. I want the most. That's dangerous, especially if you come to the Texas Medical Center. Right? When I came to Houston in 1988, one of our affiliated hospitals had 8 operating rooms going 7 days a week doing coronary artery grafts. By the mid-1990s, when managed care penetrated the market, only about 5 operating rooms were going 5 days a week. There's only one explanation for this. The introduction of managed care reduced the rate of cardiovascular disease in my city. Right? There can't be any other explanation, right? So patients have a right to effective health care. Who invented this idea? The framers of the American Medical Association Code of 1847 figured this one out. They had already gotten this well understood. And payers only have an obligation to provide for effective health care. That's it. Nothing more, but nothing less either. And then patients should be incentivized to make and implement these decisions. For example, remove all economic barriers to patients with chronic diseases, regardless of their income status. Just take all the economic barriers away. United Healthcare, of which I'm a member, if you have a chronic disease, you will get called by a skilled nurse practitioner asking if she can help. You will be given a booklet with the 800 number and encouraged to call and said 24/7, you can get an advanced nurse practitioner to help you with your problem. And it reminded me of Kaiser of Northern Virginia, which invented that way back in the 1980s, in the ancient times when dinosaurs were roaming outside our medical clinics. So we have to school patients in the virtue of prudence. Figure out what your self-interest is and then act to protect it. Getting an appropriate amount of health care is in your interest. Not getting too much not getting too little, or God forbid, getting the wrong care altogether. So we should base health care reform on a right to, or I would say preferably an obligation to provide effective care provided by evidence-based reasoning. You limit the autonomy of healthcare professionals to practice as they want, but require they practice as they should. You limit the autonomy of patients to think not as they want, but as prudent people should. And what we will get out of this is a scientifically and ethically more disciplined gemisch. We'll still have one. Our cultural values aren't going away. And we will still have the gemisch, but it should cost less, and the rate of inflation in it should go way down, and the outcomes should be greatly improved over what we have now. I'm now going to turn this over to my distinguished colleague, Professor Weir. Stephen, step up here, please. And I think this is yours. Slideshow from beginning. Use the good trade mics. Use the right arrow. Don't use this.
Okay. Pockets?
Yes, sir.
Okay. And this is the mic I go on.
Yeah, you can go. That's
is there a mic here too?
No.
Okay. Okay. What I have on my slides was basically came from me seeing Dr. McCullough's slideshow. And partially I didn't read it right, but I'll go through some of it. But he's really given us a lot to think about, so I think I'm not going to do another 45 minutes on you, okay? I'm going to be a little more efficient. I don't think I have that much. Actually, I was thinking of a cartoon I saw one time, and it was a cartoon of Ronald Reagan standing at a podium about to speak, and the caption over his head is something to the effect, "I'm about to depart from my prepared remarks." Okay? And in the background behind him, you can see there's about 4 or 5 people emerging from the back of the room with their hands like this. They're going to grab him. Okay? Because Ronnie wasn't quite as good when he departed from his prepared remarks. Anyway, we'll see if I do a little better. The road to serfdom, death panels, cheap health care, whatever. The road to serfdom is a reference to a conservative kind of demigod, Hayek, who was an economist who basically pointed out similarities between Nazism and communism and said no matter how you cut it, socialism will lead us all back to serfdom. Okay, we'll spend some time with that. Death panels, a little bit about Sarah Palin, cheap health care, whatever. I pressed the right-hand thing, huh? That didn't work. How about page down? Will that do it? I pressed that one there? Oh, that one, yes. Okay. First of all, and it's a little clear, this is where I partially misread McCullough, but I think that it still merits mention. The talk was advertised as, quote, ethical challenges of healthcare reform for physicians and healthcare organizations, a philosophical debate. Okay? So as I was reading Dr. McCullough's presentation, it sounds like, well, we've got rights language again, and I have a bit of a problem with that too. As Dr. McCullough pointed out, it tends, well, let's just go through it. Where's the beef? That is the philosophical argument, right? Dr. McCullough reports, the appeal to a universal right to health care rests on either natural rights or human rights. But then all of a sudden it turns out we don't really get arguments for those. As he says, natural rights are usually negative rights and therefore not an adequate basis for the right to health care. So we don't get these rights from there. Then he goes on regarding human rights, quote, the reasons or justifications for creating the rights are finessed. I'm not sure what a philosophical argument is that's finessed, but okay. Because attention to those reasons or justifications will divide us and defeat the purpose of human rights, to improve the social, economic, and political condition of human beings. Now, when I saw that, I was thinking, okay, what we have here is the Hastings Center approach to rights. I don't know if you're familiar with the Hastings Center, but it was this kind of think tank that started, I think, back in '69. A bunch of us. David, were you there too? Did you go through there? Okay. A bunch of us went through in various forms and got our union cards punched there, and it was certainly good for our careers. But I can just remember something while I was there that was kind of iconic for the place. There was this long discussion. It was probably a day-long thing about some issue. I forget what it was. But then in the end, Dan Callahan, who was the kind of head guru of the Hastings Center, asked the real question. After all the discussion and what's important and how to sort this out, he says, but should we call it a right? Okay? This is rights as trumps. This is rights as we don't have to go through a lot of argument. If we can get people thinking about it as a right, that's it. We don't have to bore the details, and we can also ram it down the throats of anybody that doesn't think so. Okay? And it was always interesting because, again, my memory is, he'd ask that question, and everybody would kind of sit around, and nobody'd say too much, and it was almost like they were connecting up with the lower part of their large intestine to kind of figure out, is it a right? Because if it is, then that means we're going to be that much more, I don't know, violent about protecting it, getting it, I'm not sure. But that seems to be the approach. I guess my point is, even though McCullough says, and I think importantly, makes much more sense to talk about as an obligation. From wherever we're coming from, whatever our background, don't we have an obligation for those that are disadvantaged regarding their health care and the bad effects that has on us? Okay? I think that raises up a lot of things and turns it into a political issue, not something that, well, it's a right and that's it. Then we're done. It turns into a political issue, which means, among other things, what will be the effect on other things in the society if we do this or don't do that. And that's what I'm going to talk about, and what I'm going to refer to is Obamacare. Okay? Maybe I can help you out here so you don't get the wrong idea. I agree with McCullough for different reasons that I think we do have to do, as Obamacare has done, expand health care to all those folks for various reasons, including it's just bad practice. A number of the reasons that McCullough gave. But it is an eminently political issue, as McCullough says. The goal is to assert a human right and then use instruments of political persuasion and action and ultimately state power to expand the scope of rights holders to include all human beings. All I throw in here is I think we have no argument for it being a right in the requisite sense, and we ought to just talk about obligations. That's where the power is, I think. And that might be the place where people can, first of all, more readily get involved with, well, what is the obligation, what does it entail, and more readily identify what are the effects on the rest of the society. Towards that end, okay, goal number one of healthcare reform, creating a source of payment for nearly everyone, universal coverage. Lacking philosophical argument, we resort to the issue's political aspects and judge all things considered. One, would it be nice to provide universal coverage? Of course. Two, would it be prudent to provide universal coverage? Well, it seems so, at least for the sake of patients, but what is the political, environmental effect elsewhere? And then three, can we afford it? Certainly not. Parentheses, if McCullough can make unargued assertions, so do I. Anyway, let's talk a bit about Obamacare. Let's have what is it when we're going to do something weird well, for example, I put in a half-acre pond behind my house without getting a permit for it, because I knew that if I tried to get a permit, I'd have to go to about 10 different organizations who all felt that they had they could pass on that. And I knew that if I started to do that, I would never get my pawns, right? So I just put it in, and then one of them caught me, and I had to pay some money, but they didn't make me fill the hole back up, because it was already water and fish in it. I was quick about that. If I was following the numbers, I should have done what do they call it, an impact statement? It's an impact statement? Okay, let's do a political environmental impact statement on health care reform a la Obamacare. Okay, one is November 2010, right? An awful lot of people in exit polls made it clear that part of what they were very concerned about and very unhappy about was Obamacare. And that was known when it passed. Okay, to the extent we think we're a democratic country and we're somehow keying to what the voters think, that certainly wasn't the case. Two, and I think this comes out of November 2010, an increased sense by many citizens that government does not care what they think and has no fiscal restraint whatsoever. How many trillion was that? Where are we? Was it CBO keeps upping what it's going to cost, right? Three, I would submit to you that this is the abortion issue for this century. You think this is a bitch. Let's put it this way. It was not done on any sort of bilateral political consensus, okay? Same thing you could say is true about abortion. I happen to be one of those that think, arguably, if we'd rather than the Supreme Court stepping in, I'm going to anger a lot of people in here, I suspect, but if the Supreme Court had not stepped in with Roe versus Wade and let it work out, because many states were expanding that opportunity, okay, that maybe it wouldn't have lasted as long as an issue if we hadn't rammed it down the throats of a fair amount of people that were not comfortable with it yet. I worry that the way they did Obamacare is going to be the same thing. Look what's happened. We got the Democrats control Congress. They got that through. Now we've got Republicans sitting there in the House, and they're going to say no. Okay? If you thought what we had was a gamish, what are we going to get? What's the gamish going to look like if we go back and forth every 2 years, depending on who lucks out, and they start tweaking it? Arguably, if we had statesmen in Congress of any sort, somebody might have said, there is no way we can do this unless we've got bipartisan agreement. We should not, particularly given the lack of it that we've got here. You might think about that. For what it's worth, I'm ambivalent about that myself, if truth be told. We have certainly got in the idea that we're going to cover everybody. That is in under the tent. We're going to have to deal with that. We also have what Dr. McCullough is talking about with the, what is it? Accrediting organizations? Accountable care organizations. We've got that too. It would be a complex political judgment to say whether that's good enough and we'll muddle through with the rest. I worry that what we're going to do is it's going to be a political football and we won't get anything remotely decent for years. My strong worry is that what Pelosi and them did, I wish they hadn't. But then the question becomes, well, could you have gotten them together later? More Democratic bureaucrats. Dr. McCullough and I were going back and forth just this morning, and I was mentioning the thing that, well, of course the Republicans are going to be unhappy with this, and any conservative would be, because there's certainly a lot more positions for Democratic folks and situations where you'll have more people dependent on the government. And those of us that aren't totally Democrats might not like that, so we're going to fight it. I'll leave that. Death panels. It's interesting. Arguably, the right has matured a little bit politically. There's no sense in which there are death panels anywhere in Obamacare. It's really a myth on one level. But can you imagine people like Sarah Palin and the rest saying, first, they really don't like this because it's a boondoggle for the Democrats. Secondly, they really think that what's being finessed here is rationing, big time. I mean, if you think about it, they're going to add a whole bunch of people to Medicare and Medicaid, and they've taken $500 million out of that. How can you do that for all that Dr. McCullough talks about better systems, better processes? How can you do that and not offer less? I'm 65. I'm about to go on Medicare. I haven't retired yet, so I don't really have to worry about it. But even with all my contacts, I'm going to have to look around and probably beg a little bit to get some doc to pick me up when my current physician retires, which is shortly. And I don't even know if I can do that. Okay? No serious malpractice reform. I don't know if this is true, but Dr. McCullough and I were talking about this before then, and he said, well, Congress could not have, and this is often a criticism of Obamacare, his point was Congress could not do that. That's a state thing. Only the states can do malpractice reform. Now, you see he's nodding at me. Is there a lawyer in the audience that knows better about that? I did not know that. It's certainly a criticism you hear all the time. Let's see. Which way to Tahrir? Is it Tahrir Square? Some unhappy Egyptian certainly said that once upon a time. What number 8 goes to is the last question. Do you want to trust health care to these people? Is your life better now than 4 years ago? I use 4 years rather than 2 because I don't want to just beat up on Obama. The Republicans certainly showed that they could spend money like drunken sailors just on other stuff. They certainly bailed out all the banks, et cetera, et cetera. And I've spent a fair amount of time reading around about the whole financial crisis and how that happened, and it becomes clear that they were all culprits, both parties, the regulators, what's the guys that, the ratings people. Everybody was in collusion because as long as the housing market was doing well, then these subprime mortgages are really generating very nice income. For all I know, a bunch of you profited from that, right? As long as things was going well, and nobody stopped it. So the question is your life better now than 4 years ago? Are your stocks worth less? My guess would be they are. Mine certainly are. Your IRAs, value of your home. Didn't we all take a hit there?
Nope.
No, you didn't? Nope. Well, that's because you were absolute. McCullough lives like a couple of minutes from the medical complex, so they're still going well. All the rest of us took a hit, right? Yeah. We know we did. Interest on your deposits. I mean, 1%, how good are those 401ks going to be when we get out there and we're making 1% on our money? I mean, even if you got $1 million socked away, that's only what? 10 grand a year? You could be a millionaire. If you've got that and your Social Security, you better sell your home and get into a cheap apartment downtown and just don't go out, right? Purchasing power, your opportunities, your children's opportunities, which I'll get to a little bit more in 9. And you want to trust health care to these people? Do we really want to do that? Do we want to trust anything to them, for Christ's sake? Anything at all? The argument from justice. It's interesting that if you go to the literature in bioethics, what people usually do, and Dr. McCullough didn't rely on this, is talk about, well, it's not just, it's not fair for these people not to also be covered, right? And it's interesting, he doesn't mention that, and the thing that I always found interesting about the whole debate is people talk about justice and they think it's another slam dunk. And my problem with that is I have a 22-year-old that's about to go out in the world. Actually, he's in his last semester, and if he passes 3 of his classes, he's actually going to get a degree. Now, if you knew my son, you'd understand that, 2 years ago, I would have bet you anything. That was not what was going to happen, but somehow he's managed to do that. I have 10-year nice IRAs. I've got a defined benefit plan. I'm going to do just fine. What I'm worried about is my son. And what my view of the cards say, and I would think you could all participate in this. Even if you don't have children, you've got younger friends, acquaintances, and all the rest. Are we leaving the world better off for them? Are their opportunities going to be anything like ours were? I think the answer is clearly, enormously, no, they're not. Actually, if there was justice in the universe, when the baby boomers come up to say, okay, I want my Medicare, my this, my that, my defined pension, my Social Security, what we ought to tell them is, no, you and Al Gore didn't put the money in the lockbox. You already spent it. Okay? You were very liberal. You spent on this, that, and the other thing. You invaded Afghanistan. You had, whatever. There's no money, sorry. Take a hike. The next generation would be just to tell us that. But we're going to saddle them? America, how can I sing you a holy litany in your silly mood? Allen Ginsberg said that a long time ago. If I had enough time, I would actually read from, I think is it Howl, where Ginsberg talks about Moloch, whose brain is a raging dynamo, whose fingers are 10 armies. Does anybody read that stuff anymore? Some of you are old enough to remember this. All right, okay.
One of the greatest leftists of all time.
Okay, that's all right. I can deal with that. This states the problematic, I think, and I'll leave you with this. We are in the predicament of the sorcerer's apprentice. Almost anywhere we turn our horrified eyes, we see that the welfare state has a built-in, irresistible tendency to further growth. More and more areas of compulsory aid keep being discovered. More and more population groups are drawn in. The assistance rendered grows more comprehensive, and the projects adopted more elaborate. The welfare state is the favorite playground of a cheap sort of moralism that only thoughtlessness shields from exposure. But what is equally bad is that to turn back on this path is as difficult as to turn a car on a narrow, steep alpine road. This is what we realize to our consternation once it is beyond doubt that the road leads to the abyss. Thank you. Dr. McCullough?
You want to stand next to it?
Yeah, sure.
Just as long as you're close to each other there, they'll pick up both of you.
Just a couple of quick comments, then we'll open it up. First of all, if we follow the concept of an accountable care organization as I've described it, there will be no rationing of health care in its ethically troublesome sense, and that is denying any patient what evidence-based reasoning supports as good medical or nursing care. If rationing means spending less today than we spent before, then yes, there will be rationing. And there are some very thoughtless people in the ethics literature who conflate those two. And that's just a mistake. The estimate probably is that in 2010, we spent $2.1 trillion on health care. The most conservative estimates I've seen from health economists is that because of uncontrolled variation, we waste a third of that, or $700 billion. There's more than enough to finance the era of accountable care organizations and return money to payers. So rationing is simply a red herring. What's the philosophical beef behind my position? It's very simple. It's called American pragmatism. There's a long and powerful tradition behind the idea that we finesse our differences if we can agree. Also, Beecham and Childress are on my side. who are, by the way, deeply American pragmatists, although they get some really nervous when you say that to Tom and Jim. But in Principles of Biomedical Ethics, they say we don't have to agree on where the 4 ethical principles come from. We just have to agree on the rules they generate, and then we're off and running. Right? So the philosophical tradition behind this is American pragmatism, whose roots are in Hume. And Hume and the Scottish moralists taught us the following. All of us have a sympathy-based duty to relieve man's estate. What do they mean by that? Lower mortality rates, lower morbidity rates, improve the living condition of human beings. That's the driver behind the obligation to provide health care. A fine old idea that Hume had based on sympathy. Every serious religious tradition teaches the exact same thing. There are many avenues to the route I took. Taking care of the next generation are called our children and fetuses. Talk about money not being allocated for children, enough money for them. This system that I propose would set it up because the money would be freed up. So I think that's a red herring. And then trust health care to these people. On the account I've given, there is no role for government. You didn't see it in there. It's all healthcare professionals and healthcare organizations leading from below. That's how we do it in the United States if we want to build it to last. And a final political comment, Obamacare will not be altered or repealed until Mr. Obama is out of office. He'll just veto it. And the other final thing is, our Constitution requires legislation to pass with a majority in 2 houses and be signed into law by the executive. The constitutional requirement was met for Obamacare. The Republican Party made it their deliberate policy not to support any policy initiatives of this president. If it wasn't bipartisan, the blame does not rest with the president. That's just a fact of our history, and they're still playing that out. So I think but the point is there is a philosophical beef to this, but if you can find the word government in my slides, then you've got X-ray vision, because it's not there. It's not there. By the way, which government agencies do I have confidence in to produce accountable care organizations? The 2 that lead our country, Veterans Health Affairs and the Military Medical Corps. They are the leaders. Private medicine, civilian medicine, is way behind. I mean, I teach members of the medical corps. They are light years ahead of us. They have protocols for everything. And what they've done in improving trauma care in the Iraq and Afghanistan theaters is extraordinary and is bringing protocols back to your emergency room and to ours. These are government employees who are doing this. So I think that's just a canard, and I think we should just put it aside and focus on professional responsibility as our true lodestone, because that's what our society counts on. Yes, sir. Start in the back.
Dr. Ware, I don't understand why we always get the question about, is it affordable? So what is it that's important in human life? What could be more important than health? And we can afford a mission to Mars, we can afford a mission to the moon, we can afford God knows how many aircraft carriers where our main enemy is Al-Qaeda, which doesn't have a single plane. Why do we need a defense budget that's more than 7 times more than 7 times larger than our nearest competitor or potential combatant? Of course, it's true that healthcare spending could be lower, but to imply that we can't afford to spend money on people who are sick is basically a racist argument.
Racist?
Most of those people are minorities.
Repeat the question, or condense the question.
One way to put it, I guess, would be, how can you even raise the issue of not providing full health care for everybody? Does that capture it?
Because it's expensive.
Because what?
Because it's expensive.
Due to financial reasons.
Because it's expensive. Okay. Let me try to answer in this fashion, okay? Because as you may have heard me say, I think they ought to be concluded. I think particularly if you go to the obligations part of what Dr. McCullough said. I think that really should grab us all. I don't think there's an alternative there. I think a lot of people, rightly, and I share this, are very afraid that we are spending way beyond our means. Now that goes to your issue of expense, to just say, well, it's very expensive, but so what, okay? Who knows where we end up if all of a sudden everything bottoms out? I remember what happened with the Weimar Republic. We got Hitler when people were rolling wheelbarrows of money around, okay? Who knows how bad it would get, and if people all of a sudden lose all the things that they're used to getting, what sort of political folks might show up, all right? You may not share this sense of alarm, but I sense there's a lot of people in the country that are very alarmed, fearful, okay? And I don't find it misplaced. I really don't. Actually, I share it. I share it, like I said, I got tenure, I got defined benefit plans and the rest. I'm good. I worry as much about my son's opportunities and what kind of a society he's going to come into, and that's why I wanted to make a big deal about getting rid of the rights language. I think you have to take this all as a piece. It's not just health care we're talking about. We're talking about in what ways the United States will flourish or fail over the next generation or so. And I think this is part of it. And how we do that is not clear. When Dr. McCullough made his final remarks, there was one thing that I did disagree with him about, which is to say that Obama wasn't, that somehow the Republicans didn't participate. My read is they were not given an opportunity to participate because what was being talked about was not anything remotely close to what they had in mind. They were not given a place at the table. And if that's true, then both parties are equally guilty of the fact that they did not try to do something remotely bipartisan. The Democrats took their majorities in the presidency and they rammed it down everybody's throat. And I think we will get a worse gamish down the line because things are going to go back and forth depending on who gets in.
Let me just make two comments. One, there's more than enough money already being spent on health care that if we got it efficient, we would have money and probably could spend aggregate less than we're actually spending. And second of all, simply factually false. Senator Baucus, who is from Nebraska? Montana. Worked with Republican counterparts in the Senate on his finance committee to try to bring them on board, including the two senators from Maine, who were put under tremendous and unrelenting pressure from your senior senator, the Republican leader in the Senate, not to do so. Under now Speaker Boehner, then Congressman Boehner, the Republicans in the House decided they weren't part of this. Those were political decisions that they made. Those are facts. We can't make up history. Those are facts of the matter. Yes, sir.
Well, I had a question, but first I was going to add a little comment to the discussion about cost. I sort of had an awakening about 3 years ago because my youngest son was kept in the neonatal ICU for about 5 days. The bill was $20,000. I only had to pay $1,000 of it. I thought to myself, I'm actually sort of on the cusp of lower upper versus upper middle, and I can't afford that. And if that's the mean treatment, and I'm above the mean income, and I can afford it, how can we afford it? And of course, it does come back to quality control, because the issue at hand was that neonatologists didn't have to seek my approval because there was a third-party payment. I never would have accepted his excuses for keeping them. In fact, I never met him. The hemoglobin was a little high one day. There was a little bit of a residual on a tube feed the next. It was a bunch of BS, literally. And I was sort of ashamed to be a physician when I thought about how this neonatologist was milking the system. But I do think that out of all the things that I would actually have liked to have seen with health care reform, I would have liked to have seen death penalty. Because one of the key issues is that most Americans do view this as, even though it's a positive right, as a natural right because they're not educated about it. And they come into the hospital and they have to sign a sheet of paper to say do not resuscitate. Well, the pathway, the benign pathway is that you'll do everything, even though it's irrational and costly. And that does tie back into this idea, well, why do doctors do this and not assert, well, you're not, this, it doesn't make any sense. And I do think that fear of lawsuits does play into it. So my question was actually for Dr. McCullough. If lawsuits and malpractice reform would have to be done at a state level, then what does that mean with regards to the idea of having a federal mandate and this whole discussion about primacy versus nullification?
Okay, well, the question, let me see, well, I hope I can get all this, is can you try it again?
If the Healthcare Reform Act already has these sort of claims to primacy where they're going to make states follow some of these things, including the healthcare mandate,
right,
which is why there's a bunch of different lawsuits trying to seek from different states to nullify.
Right. Oh, okay.
Why couldn't they do malpractice reform too?
Okay, so the question is if the federal government can mandate participation in insurance, why can't they mandate healthcare reform? In our malpractice. In our federal system, the states regulate the practice of medicine. The federal government only has jurisdiction over the VA, military medicine, the Indian Health Service, and those direct provider groups. The state of Texas regulates the practice of medicine. The state of Kentucky regulates the practice of medicine. So Texas has malpractice reform. We've had it now for several years. There's a cap of $250,000. Before malpractice reform, plaintiffs won at trial about a third of the time. Now they win 10% of the time. If you remember Gawande's article in New Yorker magazine where he profiled the hospital in McAllen down on the valley, is a textbook example of uncontrolled variation driven by financial self-interest of the physicians who are getting rich as direct providers and as co-owners of a for-profit hospital. So it's a textbook example of uncontrolled variation in a state where you cannot attribute malpractice avoidance as a motivating factor because it simply doesn't exist anymore in my state. When the malpractice insurance companies directly after the reform passed tried to raise their rates, our dyed-in-the-wool right-wing conservative Republican insurance commissioner said no. We just passed reform for you guys. You can't raise your premiums. In fact, if anything, you need to think about lowering them because your costs are about to plummet, which is certainly true. Now, does the federal government have the capacity to mandate participation in an insurance pool is a constitutional question on which I do not have expertise. There are at least 2 federal judges who disagree, one in Florida and one in Virginia. There are 4 district court judges who agree, and so this will go through the various circuit appeals courts and up to the Supreme Court, where in our system that issue will be resolved. But there's no doubt that the government has the power to mandate participation in insurance, and the example is your state policy mandating that you purchase automobile insurance. So there's surely constitutional authority for that. If there isn't, then our current system of automobile insurance is going to be in very serious trouble. Back to your original point, is you had no control over whether your child was admitted to the NICU, but there's an article just recently I was reading, I think it was in New York Times just the last couple of days, about uncontrolled variation in NICU admission. And the reason that exists is because in most hospitals, the NICU is a huge profit center. Typically, 25% of the net operating revenues of the hospital, not-for-profit and for-profit alike, come from the NICU, that one unit. So it is a big, big moneymaker. And so there's tremendous pressure on to use it. That has eroded the standards of admission. The response would be an evidence-based approach for which children need to be in the top level 3, which in level 2, and which in level 1. And we would do that by protocol and constantly improve that based on evidence about improved outcomes. We know exactly what to do. Hospitals who do it, this article showed, I think the hospital where they did it, their NICU revenues plummeted 50%. That's a very brave hospital that's willing to provide evidence-based care, be accountable, and lose money in a major profit center. But that's how it has to go.
Mention your thing about changing what malpractice can be based on and connecting it with evidence-based medicine.
The malpractice reform is very easy. You simply make a presumptive defense against all malpractice claims, adherence with an evidence-based guideline.
Right.
That's all you got to do. and then all that will be left is non-adherence, and those, of course, should be paid out. There shouldn't be any litigation whatsoever. And that's easy to do. I just said it. The legislation would probably be only a couple of paragraphs long to do this. Who's opposed to it? Doctors are. Doctors are. Because once they accept the concept that the standard of care should be evidence-based guidelines, the insurance companies will use it to decertify physicians, and many doctors in our society will lose their livelihood altogether, and they should. This is the great ugly truth of American medicine. To the clinicians in the room, right? It shouldn't matter that if a loved one at home needs to go to an emergency room right now, it shouldn't matter which one they are taken to by EMS and which team sees them at the door, right? And you have complete confidence in that, right? Wrong. Every doctor and nurse knows this. Why has it been allowed to persist so long? Right? We know the answer to this. Aetna's already doing this. Aetna's already set up its Centers of Excellence reimbursement program, and it's going to put doctors out of business in cities where it has dominant market share. They don't care, because if you go to a Center of Excellence under Aetna's program, you have no out-of-pocket payment for major procedures like coronary artery grafting. None. You go anywhere else, it's 50% copay with no negotiated lower fees. They're steering their patients into the Centers of Excellence. What are they getting? Healthier patients who cost less money. They're aligning profit with excellent medical care. That's perfectly ethical to do. So there's the organized medicine, especially. You watch. If your legislature proposed that language, you would see the opposition come from organized medicine in the state. It's just stunning. But that would be my prediction.
And kind of just to build on that, one of the questions that I've asked previous speakers was, so how do we get this improvement happening? How do we bring process improvement, this preventive ethics, into healthcare? And his answer to me was, it's going to be a big fight because all of those inefficiencies are somebody's profit. How are we going to lead from the bottom and reform?
Right. How do you lead from the bottom and reform?
So
You insist on professional integrity.
Wait, repeat the question.
How do you bring about the reforms that this would work? You insist on professional integrity. You create an organizational culture that supports it. That will make, once again, medicine and nursing worth doing. They are at high risk of not being worth doing because their only compensation increasingly is big salaries. Right? Nurses are now paid very well. They certainly are in the Texas Medical Center. Starting salary for a nurse anesthetist at the Houston VA is over $100,000 now. And they can't hire them. Why? Because the medical center hospitals are paying more. They're not stupid. Right? So that's the answer. So it's a matter of doctors and nurses saying our professional integrity is the core of all of professional ethics. We're going to preserve and strengthen this and build organizational policies and cultures that support it. An organizational culture are the practices and policies of an organization, what it supports, what it tolerates, and especially important, what it tolerates that it should not. And that takes leadership from above and below working together. But there are examples of it. The clinic models I mentioned, Intermountain Healthcare, there are examples all over the country. We should have confidence we can make this happen.
We have to end now. We've come to the end of our time, but I want to thank our two speakers today. Thank you so much.